height check, your blood sugar check, your unresponsive check, and boom, it's gonna kick out, and it's gonna say hi. Okay, so that's gonna be flag number one. If you have no other ability to get history, so that's gonna be flag number one, boom, hi. Okay, so now we know that they're hyperglycemic. So right then and there, they're in the beginning phases of DKA. So you take hyperglycemia plus acoustical respirations, and you're like, okay, boom, okay, well, we got red flags going. Now it's like, okay, where are we? If we're at a home, go to the fridge. Is there insulin in there? Do we have diabetic meds laying around? Do we have anybody we can talk to? Do they have a medical alert tag? And so then you start to paint that picture of, all right, this is what's going on. Now, can somebody that's diabetic also have ICP? Absolutely. And so that's where just trying to get that whole history presentation of how old is this person, how are they presenting, do they have a history of high blood pressure? If they have a history of high blood pressure, now you start kind of, like, this could be somebody that popped a vessel that has diabetes because diabetes has poor circulation.
So the traumatic ICP isn't from a mechanism of injury with a trauma, it's just, it could be a traumatic from aneurysm.
Correct, correct. But it could also be from an actual exterior traumatic event as well.
Okay.
It could be from either one. Anything that really could cause ICP can lead you into, and a lot of times what will happen is if you have ICP, you'll end up with central neurogenic hyperventilation, and it'll eventually end up transitioning into Shane Stones. Okay? And so if you've gone from here to here,
Getting worse.
guess where you're gonna go next? Down to here.
Yeah.
Okay? So it'll get to that point, and then it'll just start braiding down slower and slower and slower, to the point where it's like, okay, I can see exactly where this is going. This is not going well. We need to hurry up. We need to, as also says, diesel therapy here because we're playing catch up.
Yeah.
Does that make sense now?
Yeah.
With that?
You just made me nervous with Dr. Doherty.
Oh,
So
yeah.
I like.
Dude,
Yeah,
you say your name.
I
and
wanted to
you're-
double check like where I was thinking on my history taking for DKA versus
Yeah.
central.
And so just having the, like going through, getting your whole picture first, because then you're like, I got my blood sugar, I've checked
Yeah.
my pupils, I got my vital signs, this is my presentation. Okay, this is what I'm thinking now based on everything that is there. There's nothing that's leading me towards this in meds, in history, and anything like that. Boom, I'm back to here.
Okay.
And your CO2 would be super high in Kuzmal and maybe super low in the central neurological one, wouldn't you say?
Yeah, because you're blowing off all your
Way too much, yeah.
Blowing off all your CO2.
Okay.
All right. Okay, we've covered all that. Nasal cannula. Nasal cannulas are good for what?
Low flow of oxygen.
I might need to give them oxygen.
Yeah. So the way I look at nasal cannulas are really good for patients that they probably don't need the oxygen, but it's going to make them feel good. It makes us feel good. Makes everybody really feel good. Because in all actuality, if somebody needs oxygen, what are we going to go to? We're just going to go to the non-breather, right? Because if they legitimately need it. The one thing that it does help. It does help for communication because as soon as you put a mask on, right, it becomes a lot harder as soon as you put a mask on. All right, non-breather advantages, disadvantages. We talked about that a little bit. Disadvantage, really only disadvantage is communication for it of it. People that are short of breath don't like masks, right? So then they gotta fight it, and it's like, I can't do this, I can't do this. And they pull it off. So then you try the cannula, you try and kind of work it, blow by, whatever you can do to get them going. You just hold it on their mat face. Venturi masks. What kind of patients get Venturi masks? I'll give you a hint, COPD. Because we don't want to wipe out their hypoxic drive, right? This is kind of this is more of a hospital-based thing that they do to try and wean people off oxygen. They can increase and decrease the percentage of oxygen that they're giving somebody to help not eliminate their hypoxic drive, keep their hypoxic drive going so that they continue to build it back up so that they can completely come off the oxygen and be sent home. It's designed so you can use different filters or adjusters here. The concept is you got the oxygen running through here like this, it goes into this and it's sucking in room air as well. So based on which one of these you have, the percentage that you're going to use, it's sucking in more room air versus oxygen. And so what it's trying to do is it's trying to wean off the oxygen back onto more of a higher percentage of room air. Does that make sense? So you're trying to get them off the oxygen as much as possible.
So is this a patient when would we see this patient?
Like inter-hospital transfers, going
Inter-hospital.
from one hospital to another, a COPD patient where, like, so say you're taking them from UD to Riverbend where they gotta spend more time in the pulmonology department.
We wouldn't necessarily see this patient
No.
in their
Most,
home.
most places don't even carry them anymore.
Right. Because you're not really gonna knock out the respirator,
Right,
right?
because with us, it used to be like, hey, you don't wanna give a COPD patient too much oxygen, right? And now we've gone past that, where to the point, it's like, if the patient needs oxygen, they give oxygen, and then we can manage, we become their ability, their hypoxic drive with our BVM and our cool tools that we got to innovate and take over. Okay. All right, airway obstructions, most common cause is airway obstruction? Tongue, cool, I think that's pretty straightforward. Food, teeth, dentures, toys, all of those go in the mouth and all of those get stuck. We have cool tools, we have Miguel forceps, we'll play with those in lab, so that we can play with those and get comfortable with those. I pulled an entire thing of steak out of somebody's trachea, just with the Miguel forceps. I'm like, what is that? And I got down in there and I pulled, I got about halfway out and I realized I had to do a double clutch and go down and grab the midway in because it was so long, and then I pulled it out. And then the best part was when, because the firefighter had missed it, but I took it and I slapped it on the chest of the person right as they were doing the compressions. I was like, hey, found a problem. Sorry. little things that just, all right, let's see. So upper airway, epiglottitis, anaphylaxis, burns, toxic inhalation, trauma. Epiglottitis, big deal. Mainly in what kind of patients?
Kiddos.
Peds, right? So do we want to mess with those? Emergency?
Yeah.
Yeah. Anaphylaxis. Emergency?
Mhm.
How about allergic reaction?
Yeah. If it causes an anaphylaxis.
Close. We're really, really close, right? So you have allergic reaction, and then you have anaphylaxis, right? Anaphylaxis is poof, whole thing, airway, boom, cardiovascular collapse, bad, right? So being able to be prepared and head it off before it makes it to the anaphylaxis, okay? So when somebody says they're allergic to bees and they say, hey, I got stung, and I got some hives here, it's like, what's the first thing you're gonna ask? How allergic are you? What happened? How do you know you're allergic? What happened? How far did you get, right? I once asked a patient, they're like, we give them soy medrol for respiratory distress. Boom, give them soy medrol. The crew didn't ask any allergies. They go, hey, so you have any allergies? And they're like, yeah, some sort of respiratory steroid. I'm like, and I looked over at the crew that just gave it because we had just walked through the door. I'm like, so, what's it do for you? She goes, yeah, I went into respiratory, I think they call it arrest, where I just stopped breathing. So, how do you think I responded walking into something like that?
You grabbed your epi?
So, yeah, you don't want to be like, what the? And to the crew, right? You're like, so, this is what we're going to do. Gurney's here, we're going to get you on the gurney, and we're going to get you going. So this is, and on the way, I'm going to do this, 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 and this, right? We're not going to hang out, we're not spending any extra time. But am I going to be like, dude, you guys just gave that? No, why didn't you? No, you're not going to deal with that then. It's like, because what's that going to do to the patient if you start doing that first?
It's gonna make it happen quicker.
Right? So that's something that you not want to do. It's like, I watch people go like, dude, like, this isn't working. Like, equipment, like you're in the middle of a code and somebody's like, I don't know why this thing won't shock. It's like, it should shock. I'm like, hey, hey, why don't you go out to the rig and A, take a time out there, because I don't want you coming back in, and B, when you come back in, bring the other monitor in. It's just one of those things where it's just like, you don't say that kind of stuff in front of family, in front of people, because that's all they're going to remember. These guys showed up, they didn't know what they were doing, things were broken, and that's why my family member died, right? It's not something you want to do. All right, aspiration. This is what will get people post-cardiac arrest stuff. If you do get a pulse back, a lot of times, if you didn't do a good job with your cell maneuver, and now they got your parent pizza down into their lungs, burns it, trashes the bronchial tissues. Head, tail, chin lift, we know that, pros and cons.
Wait, what was that? What'd you say?
I said head, tail, chin lift. We know
Head,
about
tail,
that,
chin
pros
lift.
and cons.
Thank you.
Yeah. I'm good about that. Let's see. Jaw thrust, boom, right there. Okay, so that's what it looks like. Really uncomfortable. Oh, it's really uncomfortable. Like, you can actually kind of do it on yourself, but you really stop yourself before it really happens. So when you really do it on someone in real life and you're really doing it, you're legitimately lifting that jaw. Like, it is an uncomfortable, like, thinking like, I feel like I'm gonna just dislodge, dislocate their jaw when you do it. Okay. Suctioning, got all kinds of suction that we'll go over. blood, loose teeth, and vomit.
What do you mean
Where-
suction will go over? In lab? or-
Yes, in the lab. In the lab, we'll cover that stuff. Yeah, anything that I breeze through here in skill stuff, we'll hit in the lab. This is just an older PowerPoint that I have from when we actually had to do this in like 4 hours. So I had to stretch out the time. So, suctioning. How long do we suction adults?
15 seconds.
Yeah, lots.
10 to 15 seconds.
Okay, what about kids?
5.
5 seconds.
Okay, do we suction on the way in or on the way out?
Oh, yeah.
Why not on the way in? Okay, what's the difference between hard and soft suction?
One's hard,
We
one's
use
soft.
Hard suction.
What's that?
Obviously hard and soft, right? Well, let's talk about the devices. Are they different types of devices? Okay, where are you limited when you suction with a hard suction?
Upper.
Okay, basically the pharynx, posterior pharynx area, okay? Limited there. Soft suction, can we drop soft suction down in an ET tube? Okay? Can we drop soft suction into the oral cavity just like that?
Isn't as effective.
So the idea with the soft suction is you don't want to go anything farther than you can see in the oral cavity with soft suction, okay? So if you have to suction farther, a lot of times what you're going to do is you're going to place your advanced airway, and then you're going to use your advanced airway to suction below. Does that make sense?
No.
So if you're
You're
suctioning
gonna put
first,
through the
ET tube.
through the ET tube,
Mhm.
and then close off the ET tube, so that becomes your Yonker tip.
No, so you're
That
gonna
just
drop-
comes your pilot.
That becomes your pilot,
Got
yep.
it.
So basically, you drop that, it's like a well, you drop it down into the well, get it all the way down in there, you measure, typhoid process-ish, there we go, sternal notch, just below the sternal notch, angle of Louis, there we go, angle of Louis. Angle of Louis, corner of the mouth, tip of the tube, and then you drop down in there, you don't wanna go down past the carinas, right? You wanna stop before you get to the carinas, and then, so as you suction out, and then you'll rinse it, do it again as many times as you need to do it, okay?
The book had said something about adding 3 to 5 mils
Saline?
of saline to the lung and then suction that out.
Yeah, so that's something that you can do to help if it's something that's very thick mucousy or severe, they've aspirated a lot of stuff where it's a thicker fluid versus just like generalized phlegm and type stuff. So if it's a lot thicker stuff, then yeah, you want to dump that up, kind of spread it out a little bit, and then be able to suction that. Okay. So there we go. There's our Yankauer. Corner of the mouth to the earlobe. There we go. Measuring that one. Complications of opening the airway. So obviously all of these: vocal swelling, hemorrhage, vocal swelling, vagal stimulation. What is vagal stimulation going to do? Hypo what?
Bradycardia, hypotension.
Yeah, right? So anytime with extended period of suction, you have to have the person on the heart monitor because they will Brady down. Especially if you're posterior pharynx suctioning, if you're suctioning out of the ET tube, any of those, and you're highly likely to cause a patient to Brady down.
That can happen within 10 seconds?
Yeah, it can happen just any irritation whatsoever. You just happen to hit the, stimulate the vagus nerve just right, then it'll end up happening immediately. Yeah.
After you stop suction and stop stimulation of the vagal nerve, will it then come back?
It should come immediately back.
So you're just watching the monitor?
Yep, you're just watching the monitor, continuing to keep an eye on it. Yep, it should be like, as fast as it dropped, it should immediately then flip and respond. Okay, you guys are good on all your OPAs, right?
Correct.
OPAs measured from the corner of the mouth to the earlobe. Make sure that you guys know that. Same thing with nasal airways, MPAs. So tip of the nose to the earlobe, okay? How do you know which nasal nares to go with? BLS skill you guys don't know? Gosh, who's teaching those BLS? How do you know? So you got an
This table
MPA.
had an answer.
You got an answer? The biggest nostril, exactly. So how do you know which one's the biggest nostril?
You look at it.
Right? So you take a look and you're like, what if they both look the same?
Good job.
Yeah, it doesn't really matter at that point, right? So you move it up and then you just go for it?
Bevel facing the septum.
Bevel facing the septum. Okay, cool. Just want to make sure that you guys are learning good stuff. Let's see, so MBA, you get that. MBAs are contraindicated in what patients?
Basilar skull fracture.
How are you going to know? So when we start doing trauma assessments and you have a patient that's unconscious, unresponsive, related to a trauma, and the patient has an intact gag reflex and will not accept the OPA.
Yeah.
Check for fluid in the ears.
So do we go with an MPA?
You use caution in using an MPA.
So what kinds of things are you looking for?
You're looking for raccoon eyes, battle signs.
Are you meeting
But from when I did my field guide on this, it said the basal skull fracture, all those signs are late signs that you normally don't see in the field. And the basal skull fracture wasn't necessarily a contraindication. It was in the research. It was in two patients that had a basal skull fracture. So, and you don't tell it's a basal skull fracture because it's a late sign. So it was more so with big facial trauma.
Yeah, so that's the big thing. So the massive facial trauma, anything to the face, you instantly have to assume that there was enough impact, enough trauma related here that it went back there, right? So we don't want to stick the MPA up in the sinuses and up into the brain cavity, right? We want to avoid that at all costs. You don't want to be that person in the medical journal that has a cool MPA picture of an MPA in the brain. So, but if you have an unconscious trauma-related patient, what's one thing that you're probably thinking?
Head trauma.
Unconscious trauma patient.
Knock their noggin.
There's probably something going on with their head, right? Whether or not there is or isn't, like most trauma patients don't just instantly just become unconscious, right? So, like if there's something going on from here to here, if you're there in a decent time, obviously if this is long duration drawn out and they decompensated and then decompensated, you usually catch them in a compensate or attempting to compensate state. So they're still kind of awake, kind of making noises, kind of thing. If they're totally unconscious and they just have this gag reflex, high index of suspicion that there's something going on with the head. Does that automatically say no MPA? No. All right, so that's one of the things that people get really concerned about is like, you know, there could be something going on with it. It's like, the thing that we're really looking for is we're looking for stability and significant facial trauma, all right? If they're unconscious, it's okay. If we find something that there's some sort of post head bleed after the fact, it's all right because there wasn't an obvious contraindication for that MPA. Does that make sense? All right, mouth-to-mouth ventilation, we do that?
I don't do that.
Depends on how well you know your patient.
Yeah.
Some patients are better than others. Mouth and nose ventilation, mouth barrier device. So these are all things that are in the national standard curriculum. It's not something that we're going to go over because we're paramedics. We got cool stuff to use instead. Right? We have our BBMs and we have those things instead. So we're going to just skip how to do all those things. You guys learn all that stuff. Advantages of bag mask. High oxygen, you're going to get a high percentage of oxygen in there. It's the highest percentage you can get in BBM with a reservoir, 100% over the top. So you can go up to 15 liters a minute, so they say, right? So 15 liters a minute is the most you can do.
Correct.
Okay, so let's say theoretically, you got your Kussmaul respiration patient, right? And you're flowing 15 liters a minute, and you want 100% oxygen delivered as you're bagging. You think you're going to keep up at 15 liters a minute? No, so you're going to have to bump that thing up to 25 probably in order to keep up, right? So the only way you hit 100% is if your reservoir is full, okay? Your bag reservoir at the back of your bag, that has to be inflated in order to get 100% oxygen delivery with your BBM. Because if you just sit here and you're just like, boom, 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 at 15 liters a minute, what's going to happen to that reservoir? It's going to be like vacuum sealed up against the back of it, right? You're going to just suck all that oxygen out. So then, now, you're back to lower concentrations, right? You might as well just go with a non-breather at this things. So it's okay to bump it up. Just because something says 10 to 15 liters a minute is the maximum flow, just know certain patients are going to require a higher flow to maintain them getting the 15 liters a minute. Does that make sense? All right. requires practice. Practice, practice, practice. Lots of practice needed there. There we go, there's our reservoir, looks pretty amazing, looks halfway full. There's the different percentages you can see there, that'll all be in there that you guys can look at on a little pad. You guys got any other ones?
No.
No, just the.
You guys need those?
Yes.
No.
That was good.
Alright, so the EC technique is what we try and use when it comes to adults, if you're doing a single rescuer. One thing you want to watch out for is you want to watch out for that hand right there. So especially in pediatrics, if you try and do the EC technique, or people with that are largely obese, you take all this soft tissue and you're pushing on it, you start squeezing that, what's it going to do to the tongue? It's going to close that airway back off again. So you want to really make sure that you're getting up underneath the jaw with those fingers, okay? So you're grabbing onto that jaw, pulling that jaw down to that mask, all right? Oh, there's two rescuer. Oh, so much easier. Grabbing that jaw, doing the modified jaw thrust. There's our Selleck maneuver. That's how the technique you're going to use. You can use the burp technique. It's the back up right push. So as you're doing it, so most people you're going to come off on so you want to go to the patient's right side. Okay, as you're coming up, just usually we'll place that in inline position for you. And that's something that I'll show you guys when we start playing with the actual devices in lab.
Why
How that
patient's
works.
right side?
Patient's right side.
Why?
It's just so most people's anatomy will line it up perfectly like that. It's just a weird anatomical thing. Right pressure, troubleshooting bag. Avoid overinflation. That's the get real aggressive. Take your time, nice easy breaths, and allow for that exhalation for sure. Trachs, we'll cover those later. Gastric dissection. I want to get to catching all that. Boom, 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 boom. You guys covered that. All right, here we go. So I'm going to finish up just really quick, show you guys the difference between the Mac and the Miller. So here, so this is our trachea here, esophagus here, this is our glottis here, all right? Glottis, and that little thing in there is your vallecula, okay? We drop down one little thing, right here. So this little groove right here is your vallecula, okay? So you'll notice with a Mac blade, all right, so your Mac blade. So as you come in with your Mac blade, you're sweeping your tongue up out of the way. Okay, so you start on the right-hand side, you come in, you sweep, you sweep, you sweep. As you come in, you're going to go past the glottis. Okay? You're going to go past the glottis, and you're going to lift up on the glottis. Okay? As you lift up on the glottis, you should be able to see perfectly, right exactly what you're looking at. Boom, there's the cord. That's a piece of cake every single time, right? Yeah.
In theory.
Wait,
In theory. Yeah.
For the,
isn't that the Miller blade?
Yes, this is Miller. Did I say?
You
This
said
is
Mac.
L. Miller. Sorry, I was bouncing back and forth there. Miller. LLL. Good. Thank you for clarifying. So that's the view that you should potentially get. Sorry, I'm hustling trying to get you guys out of here. You guys got out of here at 1, right?
12:15.
Cool. Yeah. So I want to get you guys this before. So yeah, go like 1 minute. All right. So this is your Mac now. Okay. So your Mac comes in, and you'll notice it does not go past the glottis this time, right? So it's going into the vallecula. So as it goes into the vallecula, you notice it has this curve. So it's designed to lift up into the vallecula, which will then fold this glottis basically over the backside of the tip of the
When you say glottis, you mean epiglottis?
Epiglottis, yes.
Okay.
Glottis, epiglottis. So as it goes in, it folds it back up out of the way, and it pulls that glottis. You see epiglottis. You see where it folds it back up here out of the way, and so that's the way that those are designed to be used. Okay. That being said, I use the Mac blade, and I use it like a Miller.
That was.
So what I do.
That's the question we had.
So, and this is just what I do, this is not the way it's designed, so when we play and practice with them, we're gonna practice the way they're supposed to be used, so that you guys can see the generalized function. And so, you come in, boom, you go past it, and you lift up. So your Mac blade is quite a bit wider than your Miller blade. So because it's wider, it gives you a bigger visualization. So that's why I use it like a Miller blade. Come down, get that epiglottis. I just like to get that whole thing up out of the way, and I can hold that out of the way, and it gives me a bigger view to come in. The grand view blades are designed like these, except the grand view is much wider. It's wider this way, instead of this small little narrow thing. It gives you a wider opening here and helps control the tongue a little bit. But it is a straight blade and it's designed to use the same way. So a lot of departments are starting to transition to that grand view blade because it does a lot of what the Mac does by having that bigger visualization, and you can control it just like the Miller, where it gets everything up out of the way. So, whew, and, oh, dang it, went a minute over. Questions?
With that blade you just said that's wider,
The grand view, yes.
the grand view, is that gonna depend on the size of your patient?
Yeah, you're not gonna be able to stick it in like a pediatric. You're gonna need a larger person, larger mouth. So they only make them right now, I believe, in adult sizes. And so it would be like your larger grown adult population. Yeah.
With Mac blades, what exactly is grabbing onto the epiglottis and holding it?
So that's
back?
where it comes into the vallecula. So if you were to come in with your blade, so you're gonna stick it right in here, and it's gonna go into this groove up here.
Yeah.
And it's not actually grabbing onto anything, but what it's doing is you're putting the pressure on and you're pushing, and as you push, it folds the epiglottis up to the blade.
How much pressure
Pressure
should you apply so that you don't poke through? Is that
You'll get to see today in lab, you'll get to see in lab exactly how much it takes to get those things out of the way. And just think that this is hard plastic, so sometimes they're a little bit easier, sometimes they're a little harder in real life, depending on how much edema, how big they are, how little they are. Sometimes you'll use things, and that's why I got to the point where I use it like the Mac like a Miller, because you get in there and you just can't, it won't lift it up far enough. You just, and so that's, you just go in and you just get the whole thing up. So like I said, I basically will hang out here from now until lab. So if you guys have additional questions, feel free to hang out and ask questions, all you need. As long as you don't mind that I'll put food in my mouth at the same time.
Doug should be here for his open lab too.